Good afternoon and welcome everyone. Oops, my screen just disappeared. I think it did. There we go. Sorry about that. Welcome everybody. Thank you for joining us today. I am Wynette Dixon. I'm the new Director of Program Strategy and Development at eHealth. Today's session is about the unintended consequences that can occur in health information technology and specifically data collection, even though precautions have been taken to protect the privacy of patients. I'm really excited about today's topic. I think it's one that hasn't been discussed enough amongst the healthcare industry and practitioners and executives. We know that we should be careful, and that's why we have certain things in place to protect people, such as Hipaa, and Alice is going to talk a bit more about the other ways that we protect health data privacy. But today really is about the unintended consequences. And what do we mean by that? It's really making sure that we don't create an already vulnerable situation. You know, we're collecting data, collecting more SDOH data, making these connections between the social barriers that keep people from receiving quality health care. They may have access to health care. We're collecting that data to make sure that their needs are being met. We also need to make sure that when that data is collected and it's analyzed, that we don't categorize them negatively, and that there's not a negative outcome, and they're not discriminated against, and that they are fully supported. So today, we'll just run through a few things. So our agenda. My slide will move. It doesn't want to go. Okay, I think it's stuck. There we go. Okay. So today our agenda. As I said, I'm Wynette. I'm doing the introductions, and I'm going to turn it over to Alice Leiter, she's our Vice President and Senior Counsel, and she's going to talk about the draft of the Consumer Privacy Framework for Health Data, and that's going to help us to frame this conversation, to understand where are we now, what's the importance of protecting patient data, how can it be done, and who should do it, and who's accountable. And when she's finished presenting, we'll get into our discussion led by Al Cannell, who's the President of Strategic Interest. I'm sure he's a familiar face to everyone in this work group. And he's going to really talk us through the harms, the impact, and the risk and mitigation of unintended consequences, things that perhaps we haven't thought about. Yes, Al?
We do have somebody on the chat who's saying they can't hear the speaker. I hear her fine.
Oh, okay.
Others that cannot hear, or is this perhaps... Oh, it was on my end. We're okay. All right. But before we go too far, 1A, so there's not, more folks are coming in. Do you want to just describe yourself, take a moment, if that's okay? I mean, you have very much a right to be believed, and this group has known myself and Claudia having a lot of really interesting people, and the group is either participated, learned, shared, etc. So welcome. I'd like to welcome you to eHealth and to this work group, but is it okay if you take a moment just to describe yourself and your background and your interests?
Absolutely. I would love to. I love talking about myself. Again, hello for those who have just joined. As I said, I am new to eHealth. I've been with the organization now for about a month. And my background, I've spent the past 10 years or so really focusing on global health from an international perspective. And so a large part of my programming has been focused on NCDs and maternal health, and more specifically, health system strengthening, improving the healthcare delivery system at the community level, improving the healthcare system at the service level, those who are providing service, making sure that there is good quality access to healthcare, making sure that it's affordable healthcare, and most importantly, making sure that it's equitable healthcare, regardless of the circumstances. And I've worked a lot in low resource environments. So I've seen a number of interesting clinics and hospitals who manage to deliver healthcare with the least amount of support. And now with COVID, I'm excited to be with eHealth, because now here we are going through this pandemic, and we've all seen the gaps in our healthcare system and where there can be improvements and things that we can think about. And we've thought about healthcare in a very different way. You know, we used to think about healthcare being just go to the doctor, bam, bam, boom, that's it. But there are a lot of moving pieces with healthcare. There are a number of people who are vulnerable in the healthcare system. And so all the experiences that I've had working internationally with a number of NGOs and some of the larger donors, I'm excited to really bring that experience into eHealth and excited to bring that to the work group so that we can have these really wonderful discussions and just dig deep. I love health. Especially when you talk about health disparities, that is one of my favorite topics, and I'm very much an advocate for it, and I push it. And yeah, so that's just a little bit about me. And if you want to learn more and you want to talk to me, of course, we can. I think you all have my email. I'm here. I'm not going anywhere for a long time, hopefully. And I hope that you enjoy me as much as you enjoy Claudia. I know she was around for many, many years. And yes, so for that, I want to say thank you for welcoming me.
Okay, great.
Okay, getting back to the agenda. So we talked about Al and the delay here. So I just want to run through this quickly, just some of the work group goals. I think that most of you have seen this before. You know, we're really here to talk about the best practices and share information and learn from one another. And in this time of COVID, you know, really been focusing a lot on social determinants of health and how that relates to data. And there have also been a number of other topics that have been discussed this year as well, and there'll be some more interesting topics coming. For our goals, things we've talked about have been telehealth. I think this is a major one, and the roles of like HIEs and SOH, data exchange, technology, policy, all of these things are converging in a way that they've probably worked together before, but I think it's much more important, and there's a much more heightened awareness around these three areas that converge. And this work group, I'm hoping that you know, that we can share some of our best practices publicly and perhaps come up with recommendations and create our own framework for how things should be moving forward, not only now during a pandemic, but in a post-COVID world. And I use that lightly because I think we'd all agree COVID's going to be here for a while. Some of the other forums and webinars we've had outside of data, eHealth, we've talked a lot about COVID, and we've focused on telehealth and policy and on privacy. And I wanted to share this with this group just so you know what the organization is doing in our other work streams and how active we are in discussing healthcare and COVID and data and privacy and how committed we are to this, and just to sort of pique your interest to pay attention and look out for some of the weekend readings, and to possibly, you know, as members, join some of the other work groups and just join the webinars that are offered to you. So with that, I'd like to turn it over to Alice so that she can walk us through the framework. And so Alice, I'm going to give you control very quickly. You should have it. There's about a 2-second delay, I'll warn you. So I think you should have it now.
All right. Thank you, 1A. Welcome, all of you, and welcome to 1A too. She's been such a wonderful team addition already. And I am delighted to talk about the draft consumer privacy framework for health data that I came on board eHealth to manage. It's a grant that we've been working on now for about a year. It's possible that some of you have heard a lot of this presentation before because I've been taking this on a fast and furious roadshow, but we did think that it tees up a lot of the issues that we are talking about in this work group today. And so bear with me as I run quickly through the slides. This presentation can take longer than anybody would like. So if you have any questions at the end, or if I move too quickly over something, feel free to put it in the comments or speak up. I'm going to talk a little bit about the project, how it originated, and then go through the key tenets of the framework, and then tee up, as I said, the potential harms that the framework is designed to protect against. And then, as I said, I'm hopeful that that will tee up a good discussion afterwards. This project started with a grant from the Robert Wood Johnson Foundation, and our co-grantee is the Center for Democracy and Technology. So I want to make very clear that a great deal of this work was conducted by my colleagues at CDT, and I was part of all of the work that they led, but we did it in sort of two tracks, as I will explain. And the grant was designed to address the issue of non-HIPAA covered health data. People tend to be pretty familiar with what is HIPAA covered data. Your medical records, anything that is created by or held by an entity that's covered by HIPAA, that being a hospital, a health insurer. But I think there's a lot less certainty and understanding about the fact that once data leaves the traditional healthcare system, it is no longer covered by HIPAA, it loses its HIPAA protections. And then all of the data that users enter into their phones, into their web browsers, all of their Fitbit or wearable device data, which is increasingly almost all data that relates to in any way health or healthcare, is not covered by HIPAA. And there has been momentum building for a new federal privacy law, something that would be sort of like the European GDPR. But as of yet, that has not come to fruition. And given that it's an election year and that the world has otherwise sort of shut down, we don't see that as being particularly imminent. Sorry, I did not mean to change that slide, but I will just skip right ahead. The value proposition of this project is pretty clear to us. As I said, we are seeing this as a bridge to where we want to go. It's certainly not a be-all and end-all solution to this issue, but there are real significant gaps in privacy protections for this data. And the FTC cannot be the policeman and watchdog for all data out there. It's not staffed to do that. It's not intended to do that. And so our goal was that in the interim, until we have a new law that hopefully will address some, if not all, of the issues I'll outline, that we would build a bridge. We would produce something in the private sector that would raise the bar for consumer privacy. We intend to shift the burden of risk assumption off of the individual and put it onto the companies that are doing the data collection and using it. We also think that this is a beneficial project for companies and organizations that are doing the data collection because one, it allows them to be privacy proactive, to be seen as sort of a privacy all-star, a little bit ahead of the curve, and increasingly that reputational benefit is pretty clear even from a business perspective to companies. And we also thought that it would give them some certainty that if they follow this framework, they would be in compliance with some of the more stringent laws out there. So certainly HIPAA, but a number of state laws as well. And especially for a newer, smaller company, it can be kind of daunting to try to figure out where all of the overlapping legal obligations are when it comes to health data. And finally, as I said, we see this as helping out federal regulators and oversight bodies, as well as state attorneys general, by doing some of the monitoring for them, and then referring bad actors, the most egregious bad actors, directly to the feds, rather than putting them in the position of having to, as I said, police absolutely all data collection companies out there. I think I have, oh, there we go. And just to be clear again, this visual is always helpful to me that everything on the left of the slide was not part of our project, HIPAA covered data. HIPAA is a little clunky, a little outdated, but it does its job well within the healthcare system. And what we're looking at is over on the right in this red box, this under-regulated, minimally regulated data that really is only subject to the terms and conditions of an individual technology company, and therefore under FTC regulation. The way that we structured this work was first to convene a steering committee of experts and leaders from the healthcare system, from technology companies, academia, consumer groups, civil liberties groups. We had a number, close to 60, sometimes more than 60, depending on who's showing up for our meetings, people who were involved in this work. And it was a truly amazing brain trust of people who helped us with this. But because a 60-person steering committee is pretty unwieldy, we broke into 2 work groups and we divided the framework into 2 work streams. One, what would the substance be? What would be the data standards that we would like to propose that companies follow? And then the other path was the structure of the framework. What is a framework? And so my colleagues at CDT led the substance piece. I led the structure work. And I will go through both of those tracks now, as I said, hopefully pretty briefly. Again, scope was how to cover unregulated consumer health information. The scope of that is obviously pretty broad. So the first thing that we did was try to define the health information that we would like to be covered in this, then identify the specific protections that we wanted. And then, of course, once you have protections in place, you always have to think of the exceptions to those rules. And I want to mention that we are well aware that there are other efforts out there to address this issue of non-HIPAA covered health data, and we hope that this framework serves to complement them. The framework is not intended to replace them, or certainly not to conflict them. But we really thought that this framework that we proposed goes a little bit farther than some of the other initiatives that we've been familiar with and part of. And also we worked very hard to make sure that it was consistent with the GDPR and California Consumer Protection Act protections as well. With respect to the definition, as I said, we went very broad and we tied the definition to the purpose and the use of data. And we'll talk later about why the purpose of data use is important from a risk or harm perspective. But it was our approach was explicitly focused on purpose rather than data type itself. It is a wraparound framework. There are no gaps, we believe, regardless of the data format or regardless of the entity that's holding the data. This really applies all the way around. And we also worked hard to ensure that it would be nimble. We know that technology changes quickly and data moves incredibly fast, instantaneously. And so the hope is that this framework is both tech neutral and nimble to be able to evolve over time. With respect to the protections themselves, the best way to explain this from a high level is that it almost categorically prohibits secondary uses of data that consumers either didn't explicitly ask for or consent to, or that they would be surprised by. Again, this element of surprise is very central to the potential harms of misuse of data. All of the collection, use, and sharing limitations carry through to third parties. We tried to stick with the general HIPAA policy of minimum necessary, really trying to limit a particular amount of consumer health information that's disclosed or used to only what is absolutely necessary or what has specifically been asked for or consented to. And there is, of course, as with all data privacy frameworks, the predication of clear notice and an affirmative consent process. And this was not an easy set of standards to come up with. Certainly not everybody in our work group or full steering committee was in agreement with all of them, because this approach is more stringent than a lot of the other voluntary frameworks and laws that are out there. But we believe that where we landed is the right way to do it. This data warrants the protection. It is incredibly sensitive data. And so we stand by our stringency. And then finally, the three big exceptions that are in our framework now for some of these data standards are research, emergencies, and security and product functionality. I will say that because we've gotten a lot of feedback on this framework since we released it about a month ago, we may broaden some of these exceptions, especially in this time of COVID. We've had a lot of discussions about public health in particular, but this is where we landed for our draft. To turn over to the structure of the framework, this is really what is the model and what are the accountability mechanisms that are going to be in place to ensure that the companies would actually follow these standards. And I love this slide that our colleagues at Manat, Phelps, and Phillips put together. They did another Robert Wood Johnson Foundation project before ours, scoping the landscape of unregulated health data. And we really saw our options in our structure work group as falling somewhere along this spectrum. And on the left, of course, we have status quo, which everybody agreed is not enough, not good enough, and we rejected that. And then on the right, again, one thing I will say our whole steering committee was in agreement on is that a new law is needed and needed soon. But this is not a legislative project. We didn't want to amend any regulations or propose any new legislation. So we landed somewhere in the middle. As I mentioned, there are a number of best practices and codes of conduct out there, and we just don't think those have enough teeth. And we didn't think that having another one would add anything to this national conversation about data privacy. Then, of course, if a code of conduct or a set of best practices is incorporated into a company's terms of service, that gives it FTC enforcement accountability. But as I have said a number of times, that isn't working very well either, not to mention the fact, sorry, can you go back a couple slides? Back to the spectrum. Thank you very much. Terms of service tend to be in like 0.01 font. They're very long. People don't tend to read them, even if they put their reading glasses on, because they're too long and they want whatever the product is. So we didn't think that that went far enough either. And so where we landed was the idea of proposing a new healthcare self-regulatory model. This exists, self-regulatory models exist in other industries. We looked most closely at the advertising industry that has had pretty good success with self-regulation. And although it has typically not been particularly popular in healthcare due to some trust issues, which again tees up nicely to our later discussion, we decided that we would just try to figure out how to propose a self-regulatory model that actually would be meaningful to consumers and would engender their trust. The other benefit of a private membership model, self-regulatory model, is that it does still involve the backstop of FTC enforcement. And so one of the things that we would do if we were to actually implement this model is to work with the FTC to make sure that the FTC blesses, so to speak, all of the tenets of it. And because the idea is that it's a direct funnel from when the self-regulatory body itself is not able to solve any of the issues that have come up and there's an egregious bad actor, that we would still have that FTC backstop. But in the regulatory scheme itself, it would be a consortium of healthcare and health tech companies that would form their own regulatory body that operates fully voluntarily, independently from any federal regulatory agency, totally voluntary compliance, but again, with this federal regulatory backstop. The key tenets of this proposal include a self-certification program, and the certification that a company would make upon joining the body is to the standards that I just outlined before on the substance front. Individual companies would join and undergo a thorough onboarding. They would be well educated as to what the standards are and how the self-regulatory body works. There's a very important public nature to this process. The commitment would be public. The idea is that we would become something like the Energy Star seal that a washing machine gets if they have been certified to be a good energy user. And so the companies would be publicly identified as members of this body, and there would also be a public ability to make complaints as well, knowing that the companies that they were involved with maybe had let them down or misused their data in some way. Annual assessments, audits, spot check monitoring, the audit process and the spot check process is very important. I'll talk a little bit more about the emphasis that we placed on accountability. And then although the logistics remain hypothetical because this doesn't exist yet, we thought that we would propose an annual fee to maintain the program, but we had a lot of discussion in the work group about how not to discriminate against companies that might be smaller and not have as high revenue. And so the annual fees would be based on the size of the company in terms of their annual gross sales. As I said, accountability was a big part of our focus, given that we wanted this to be something that consumers felt was actually meaningful. As I said, there is this notion that I heard over and over that self-regulation in healthcare is kind of like the fox guarding the hen house. And so we worked really hard to make sure that the accountability and the enforcement mechanisms of this model were incredibly robust. That would include independent monitoring by program staff. As I said, this publicly announced nature of any cases of data misuse, the so-called name and shame approach, potential penalties for persistent or willful noncompliance, I've talked about referral to the FTC and state AGs, public complaint gathering process, either by the public or by companies against each other. But then we also want this to function as independently as it can internally. So dispute resolution mechanisms, corrective action plans, and dismissal and public dismissal from the program if the corrective action plan wasn't followed through. As I said, this is still a draft. And as I said, we're still working through some of the data standard specifications and exceptions on the structure and some of the issues that we were really looking for feedback on and some of the open issues left. They really focus into the categories of governance and logistics. The logistics are a little bit tough because, as I said, this is just a proposal at this point. And then with respect to governance, we had a lot of discussion about whether this should be a brand new entity that we stand up or whether this should be housed by an existing program that runs other self-regulatory programs such as BBB national programs. And again, this doesn't work unless there's a great deal of public awareness of the program and public trust in it. The idea of a reputational benefit to a company who joins has to be well known. And if the complaint gathering process is to be successful, the public has to understand what this program is and how to submit complaints and what they should be expecting by companies they're interacting with that are members of this body. And so the how to achieve public awareness and trust piece is a big to-do were we to move forward with implementation of this. And then finally, on the enforcement front, as you can imagine, given the breadth of the steering committee members and work group members that I outlined at the beginning, there's of course a spectrum of how big should the carrot be, how big should the stick be. We don't want the enforcement and the accountability mechanisms to be so heavy that it would dissuade a company from joining. There needs to be an incentive for a company to join this body. But on the other hand, we need to make the teeth, as I said earlier, the teeth of this strong enough and effective enough that the public and consumers have trust in it. So that's a tough balancing act. As I mentioned, we released this draft in August. We had a 30-day comment period and received some really wonderful feedback. I will say, to pat ourselves on the back, that it was a really an overwhelmingly positive response. A lot of people, even when they had their criticisms or suggestions, mentioned that this effort has gone farther than pretty much anyone has gone before, any independent group has gone before, and recognizing that this is a really tough issue and that we did our best. So the feedback was really constructive, and I was quite grateful for that. And we are in the process of reading that feedback, figuring out which parts of it need to be addressed, what needs to be changed, or what additions need to be made. And that, of course, is work is going to have to be reviewed by our steering committee when we're finished with it. Any tweaks to the draft report as we make our final report will be run by the steering committee. And then the final report will be released at the end of the year. It will include the framework that I should mention. We're happy to, if we haven't already, share the link to the framework that I'm talking about with you all. And then the report as well will include an evaluation of the policy rationale for each of the pieces of the framework, how we got where we got and why. So look forward to that. It's going to be really exciting, and that's what I'm going to be doing for the next 2 months if anybody needs me. Then this is out of order of the presentation that I give usually, but usually in the beginning there's a fairly significant intro where we make the value case for this. And one of the things that we always really like to explain is that this is not just wanting to keep data safe in the ways that Hipaa keeps it. It's understanding that once health data is out there in a commercial setting, there are a number of harms that can come from a privacy violation that consumers aren't quite understanding. And especially given that so much of our body, mind, and soul lives in our phones now and in our computers and in our websites, it's really important to understand how vulnerable that has the potential to make us. This screenshot of an article on the right of the screen is your pregnancy app sharing your intimate data with your boss, is a really wonderful example of how that can happen. I hope that none of you have gone through the pregnancy tracking ovulation apps that I have. But I will say that when you use some of these apps for the most personal things that you're going through, the data that's collected and the information that you have to input is incredibly sensitive. You have to talk about how often you're having sex and at what time of day, and sometimes, information about you or your partner's libido, and hopefully no children are in the room. I didn't mean to make this an X-rated presentation, but it's just a great example that we don't have any compunction about sharing this data because we so badly want the service that we're getting. But the sensitivity of the data that very often is being entered into these apps or search engines goes beyond what you even may share with your doctor. So embarrassment if that data were to be shared. Sometimes you don't care about your blood pressure numbers, but you might care about your sex drive. And then the idea that through wellness apps provided by your employer or a health plan system that is run by your employer, that data sometimes can be shared, as you see in the article, with your boss. It can creep into other areas beyond employment, such as your education, if what we're talking about is within a school health system. And then, of course, there's the problem of what if the data ends up being inaccurate? A lot of times data has mistakes in it, and you may not understand that you can, in Hipaa and in your medical record, you may be able to correct that data. Once something's inaccurate out there, whether it's something that you've entered or some mistake or glitch in the system, it can be really hard to correct that, but it becomes a near permanent record of your health, and that can have unintended consequences down the line. Of course, the issue of discrimination in healthcare is hugely relevant right now as we see the enormously disparate impacts of COVID across different populations in this country. And your health treatment, once that data is out there, can be affected by what you've entered about yourself into these commercial apps. You also lose autonomy over your data. You are not a HIPAA covered entity, but your brain is a lockbox until anything that you share is sort of out of the barn, so to speak. And so once something's out there, you really do lose control over when it might be shared, when it might be sold, either legally or illegally. And that is something that can really have a creep into people's lives that they don't fully understand always. And then ultimately, as we've seen in recent Hill hearings and election coverage and how these big tech companies are affecting them, we're not in a particularly trusting place right now with big tech. And yet there is enormous potential of healthcare technology to improve healthcare, and health outcomes. And so this idea that we would be unintentionally leading to a national undermining of trust in technology and health services is pretty dangerous, and certainly something that we thought about as we structured this framework. So with that, I'll stop talking. As I said, I'll make sure that all who want it can read our framework. I recommend having a nice glass of wine and sitting down with it. It's a real page turner. But I would love to hear any feedback that you all may have. As I said, we're not releasing it for another couple of months, so the window for feedback has not closed. And with that, I will turn it over to Al. Thank you so much.
Great. Thank you very much. Very interesting, and I certainly appreciate and applaud all the thought that's gone into it. Oftentimes when you come to a new space like this, where there's not the regulations and or the norms that exist, we usually run too quickly to come up with more of the answer and or the solutions, and a little less on the how are we going to monitor or provide governance to the situations that may occur. But in this case, you've done a lot of thinking with a lot of people and have some very good perspectives on how we can set up the process and the system and the way to sort of perhaps provide that governance. And we're still catching up with what are the different, those are some very good, we'll call them use cases or unintended consequences. Has there been any effort yet, or when does it occur where we actually have either specific use cases or specific data types that are defined, or maybe some data exclusions, things that are not included, and or scenarios, so that we can come up with the approach on what is allowed or what is approved by this group and what is not. Is there any thought yet as to when those will emerge? Like, HITSP and some of the federal standards groups have all sort of gone through the different efforts to grasp at what are, instead of speaking in euphemisms, coming up with the tangible pieces. When, where, and how will that emerge, I guess, is a question. Has there been any discussion on that?
That's a great question. Yeah, we talked a lot about use cases in the beginning of this project, and before the healthcare definition, the definition of the data that would be covered by this framework, the scoping discussion was a lot about use cases. I don't know that that is something that will be in the final report. I think we're sort of where we are now with the standards themselves and the policy rationale behind them. But we've applied for a second phase of this grant with Robert Wood Johnson Foundation. We're hoping to bring it to implementation, this framework. And so a lot of the work that will have to happen in making this a reality will involve, as you say, being more specific, being more tangible, being more real world. And I do think that will be an important part of the next year of work.
Yeah, and it's almost okay that it's not in this phase. Maybe some examples.
Yeah,
not a bad thing, but it's almost a parallel work that perhaps some thought should be put into, so that we capture the essence of what all the different data types and or use cases that are problematic and the implications, so that we can then take your framework and apply it to that set of things. It's almost separation of church and state might be better than trying to put it all into the same effort. So
yes. Well, I'm glad to hear you say that that's not something I need to put on my to-do list for, the next month or so, but I'm with you 100%. And I do think, I know what kind of work needs to happen to stand up a self-regulatory body. To finalize the standards, I do think that this parallel track of work with the data types, use cases is going to be a big part of the substance work in the next phase.
great.
Thank you so much.
So we did have a question in the chat, and I'm pretty sure I know the answer to this, but are these slides available? And if not yet, when will they? Are you going to wait until your framework is?
No, you can have these slides and you can have the framework. It's on the eHealth website, and maybe after this webinar is finished, either I or someone on our team will send around a link to the framework itself and to these slides to all the participants.
Great. And so I have some questions, and I want to get some sort of discussion going on some topics and some aspects of this. But before I do, I want to poll the floor and say, are there any questions? Would anybody like to ask a question, either in chat or in person? It's a rare opportunity to have the expert while it's hot off the press. This is meant to be a group discussion.
I'm trying to unmute everyone now so they can talk and jump in.
Okay. Any questions?
I'll take that as a sign that everybody thinks it's perfect and they're all going to be supportive and join. So thanks, guys.
Great. Well, then, there are a couple of things maybe that I can at least get it started with. That is the whole notion of, forget when the specific use cases come out, but certainly there's an acknowledgement that the potential risks are significant, and you mentioned a few of them today. Social determinant information being shared in the wrong hands. So, there is the notion that clinicians should be able to get a glimpse into that aspect of a patient's life to be able to give better care. Yet the reality is there's this view of how far should that limit go? There's this phrase, medicalization of social determinant data, that I found in an article in the Journal of Internal Medicine. So in other words, it's okay to let your doc know you may have problems getting to appointments, but if you can find a way to address them, you don't want them to be over involved in managing that part of your life. So where is the dividing line between the clinicians and the social services agencies that are providing some help? Another being the agencies themselves. So agencies are usually entitled to information that has to do with the services they provide for you. And a norm is that they also get some additional information to round out and understand the person as a whole and what some of the needs are. But sometimes what you'll find is some of these agencies, unfortunately, we have so many well-intentioned agencies that have financial problems and challenges, so they use a need of a patient to be an opportunity to help sell their services. And so, you know, how much of that information should be available there? Employers, you mentioned that is clearly a challenge. The MCOs and the payers themselves, the MCOs, managed care organizations, there's no doubt some of this information will be very valuable in helping them provide holistic care for you and to be able to give you an opportunity to have better outcomes. But if not used in the proper forum, might it end up in a result of being denied services, being denied insurance, and who knows what happens here with pre-existing conditions. So I'd just like to open it up and see if there are some other sort of entities that people feel might be challenged or might be inappropriately able to use some of this information with an unintended consequence. So this is the audience response part of the meeting. So come on, let's have a conversation.
So while people are thinking about what they want to ask, let me ask you, Al. We know unintended consequences. There's a number of ways that data can be used in not so nice ways, and we know it's unintended for a reason, right? Because it's things that we're not necessarily thinking about. But you just mentioned a couple of things with those who are not insured, right? Someone might respond with, well, what about Medicaid? And so my question is, how do you think that data is affecting those who may not be eligible for Medicaid? And do you think that there's a connection between those who may not have Medicaid, who may not, maybe they're not entitled to federal services, and possibly being discriminated against receiving health care and not having the access to health care, or funding not being allocated to support those that don't have insurance? Do you think that that's a larger problem, or is that maybe just rare occurrences?
Well, I do know, like in New York, we have this large program, I think 11 or 12 states have it, called DSRIP, Delivery System Reform Incentive Payments. And it's all about care for those that are on Medicaid and uninsured. And one of the major aspects of it when it first came out into New York was to have some focal point that could help people that are eligible for Medicaid but are not yet on it to know about it and to help them get that. And that in itself was viewed as one of the, and that's around the same time that the exchanges were coming out, and it was important to help people get insurance that were eligible for that. So I think an important part of this whole initiative or set of initiatives is to be able to direct people to those places that can be supportive, because some just don't have the knowledge themselves. I don't know if that answers your question.
Yeah, absolutely.
Yeah.
And so I have another question based on an article that I read today. As we're talking about vaccines, we know that vaccines are currently being tested, and that the government or agencies, I should say, are devising a plan to determine how the vaccine will be distributed. Because I think we can all agree that there won't be enough vaccines for the entire country at the same time. So with this collection of data, and as we talk about like the social determinants, and we understand there are social barriers to health, so there are some vulnerable populations. There are 4 phases that were identified in how the vaccine will be distributed. And phase 1, I believe, was frontline healthcare workers. Phase 2 might be people that have comorbidities. Phase 3 was people who may have chronic issues, and I might be stating this out of order. And phase 4 captures everybody else. Now, with this data that we're talking about and this data privacy and collecting data on SDOH, do you think this is going to affect, or what do you think the harms will be for determining who will get the vaccine? Because from my perspective, I feel like we might be vaccinating in the wrong order, perhaps, and there might be some people that are overlooked, and there's some people that maybe don't want to share some of their data. What do you think about that? How does this play into vaccine delivery and deciding who's going to get the vaccine when?
I think that as soon as you make it one of the criteria that is used for rationalizing it, it will be used against some certain people and used for those that are savvy enough to figure out how to use that information for the constituents they represent. So for example, an MCO, managed care organization, is going to find a way to comb their data and get the people that they represent that vaccine as quickly as possible. And there's nothing wrong with groups that represent individuals to pursue their self-interests. I just feel bad for those that don't have groups that represent them as well, may be tier 2, 3, or even 4 of that. I don't want to be a doomsayer, but I hope we can find a way to be a little less discriminating. But history shows that probably will not be the case. Anybody have an opinion on that? No one wants their voice heard.
So we have something in the chat. I'm trying to read through it quickly.
Yeah, no, I got that.
Got it. Okay.
I want to give somebody a chance to speak besides the 3 of us. Anybody? Come on. We have a question on medical information bureaus, MIB. Will they have similar insurance to the non-HIPAA bodies that MIBs have today? I'm not sure, Alice, if you have an opinion on that.
I don't. Sorry, I didn't realize my video turned off. Hi, I don't. Could you say it one more time? I don't know much about medical MIBs. Medical
Information Bureau. Will they have
Yeah,
similar?
this is Brian. Can you hear me?
Yep.
Hey,
Excellent.
you got the one. Thank
Yeah, I apologize. I don't have a good microphone here, so hopefully you can hear me clearly. So medical information bureaus, particularly in the non-HIPAA space, collect very robust data. For example, if you're involved in a car accident or a workers' comp case, they hold that data. There's a lot of property and casualty insurers that will use that data for underwriting purposes, and otherwise it's not subject to HIPAA at all because they're not covered entities or BAs. It is released by the individual. So for example, if you go on leave or you have workers' comp or you're in an accident, all of those releases that you're filling out for your physicians and others to release your medical records places all that data outside of HIPAA, right? So my question is whether or not this group has considered whether this voluntary framework would extend to those more formal but less visible data aggregators that hold very fulsome medical data.
It certainly was not part of our discussions, but I will bring that to the group because that's a good point. And I think the hope is that this framework would be incredibly broad. That said, we were really focusing on commercial companies, and yet that's a wonderful thing to add, as I said, to phase 2.
Okay, and if you don't mind, almost a follow-up on that question regarding social determinants of health, right? So, and I completely understand and agree with, there's a line which may be going too far where you're combining that data with health data. I know in our space, healthcare, we find a great value in the social determinants of health data, and we can often use it to better engage those that we're trying to provide care to. So one of the things that has worked seemingly well, despite some of the challenges, is having those non-covered entities, folks that are completely outside of HIPAA, engaged in that process. So for example, with homeless shelters, trying to find folks that are on Medicaid who don't have a permanent address, to remind them about some, annual visits, right? Wellness appointments, things like that. We've made a lot of progress in that space, and I would just want to caution that we don't undo any of that. And maybe one way of thinking about it, if it has, it's probably already been thought of, but if it hasn't already been thought, kind of like with the MIBs, do you carve out those entities that have an authorization from the individual? So for example, if I'm homeless, I give an authorization to my shelter that they can receive my protected health information from the Medicaid agency. Would that then, make that group exempt from following the framework? Because I'm concerned in doing a lot of pro bono work with nonprofits.
Mm-hmm.
Any sort of compliance regime is really challenging for them, right? They don't have enough staff and resources to do what they need to do today, especially if they're outside the Hipaa space, and then layering some framework on top of that for the nonprofits could be, very detrimental to them, obviously. But I totally understand we got to hit the right balance.
Yeah, no, that's a good point. I'm just writing it down. You're right, and it's always the issue in health privacy to begin with, that the data that most needs to be exchanged and that we most need to have be shared is also the data that people are most sensitive about, and the privacy risks are the greatest. That's why I think this area is so important. But your point's well taken. I was just taking notes, and I'll make sure that we think through that.
Perfect. Thank you very much.
Yeah.
I really appreciate it.
If you don't mind, Brian, I want to double click on that a little bit, because I think that's sort of at the heart or the essence of it, right? I mean, if we're really talking about getting an ability to understand people's needs and share them with those that can help, that very capability, like good closed loop referral from clinical to CBOs and CBO to CBO and care coordination organizations, just by doing so, we're providing that information to entities that may have the best interests of that client or individual at heart, but there's other ways that information can be used intentionally by those people. So if we carve it out and make that information not available because of the risk of how it might be result in an unintended consequence, we're going to minimize the upside and the value from doing so in the first place. The other one is, as we all know, or many of us do, Hipaa had great intentions,
yeah,
but it actually gridlocked care in many cases because many organizations were overly conservative about it and or didn't know how to best and most efficiently provide the safeguards included, but still let free flow of information occur. So no information exchange occurred, whether it was via fax machine or the more modern ways. So if we put too much of a strain on the organizations that need to be able to share that information efficiently and effectively, they won't be able to, and there will not be this sharing that we desperately need. So how do we strike a balance between it being effective, not unintentional uses, and not too hard to share and safeguard? And I don't know that anybody has an answer, but that'll be the holy grail, is to sort of balance those two.
I think you're absolutely right. I mean, where that balance lands and where that line is drawn is going to be very very difficult to figure out.
Yeah.
Thank you. I appreciate it.
Okay. Any other questions from anybody or comments? So some of the other aspects of information sharing that are, somewhat sort of in the blurred lines between clinical and or social determinants, advanced directives. You say it's a formal part of the record, but some people view that as my own personal thoughts or wishes. And sometimes it's not officially in a medical record, yet you get in a situation where a lack of that needs to be addressed. Obviously, behavioral health, not only the behavioral health aspects of clinical conditions, but there's behavioral health implications of the social determinants of health. So which is the cause and which is the effect? We certainly can't can't completely separate those two. Same with substance abuse. And how do we make sure that we're, not resulting in either bias or assigning labels or being denied a service that someone otherwise is relying upon, or perhaps losing a job, right? Sometimes you could lose a job, or maybe the home health agency doesn't want to come to a neighborhood because they fear it's unsafe. And it's not up to me or anybody to say whether a home health nurse should or shouldn't go, but it's just becomes a very, there's no right answer as to what information can and cannot be shared. So, any other thoughts on either information that is incredibly sensitive, or organizations or ways in which it potentially could be harmfully used? If not, we have about 3 or 4 minutes left, and what Jen wanted us to do. So I recognize some of the names, but many not. So we've done a whole variety of different subjects with this work group. And so moving forward, what are some of the other topics associated with social determinants we'd like to maybe discuss? 1A, I don't know if you have any, you want to throw some out there, or we had discussed some, and we're always looking for best practices. This group is as good as the best practices we have.
Absolutely. I think one of the biggest and most important thing really coming is diversity in clinical trials and in vaccine distribution. I think that's something that we should all be thinking about and talking about, and participating in the conversation as much as possible, because it is going to be, the decision will be based on data that is collected. And the definition of vulnerable populations has changed. Many more people are in the category of vulnerable population just because of the pandemic. So I propose that we do think about that, and we talk about that, and really talk about it and have a conversation about what that means. Even as kids are going back to school, there's some schools that are going back and some that are not, just depending on how active or how influential the parents or the school board, they might be. There's also, I think we should also be thinking about really talking more and more about data and how this data will be used going forward. As we think about patient matching, that means that there's going to be shared information. What does that look like? What are the upsides and the downsides to that? Are there things that we should be concerned about? And I'm certainly not a Debbie Downer about data. I think having this data is so important. I think it's incredibly important. And it's the way that we can provide the most holistic care, by understanding where the needs are, and who needs what services and who needs a certain amount of support. But I think that through this data collection to understanding healthcare, we should be very mindfully aware of what the negative fallout should be. And it doesn't mean that we're bad people for collecting data. It just means that we should do our extra due diligence to make sure that we protect, the privacy of the patients that we're most concerned about.
Great. And I'd like to ask